Hi, let us study together today fibroid uterus. This is me, Dr. TSR here. So, fibroids, we know it is the commonest benign tumor which is arising from the uterus. It can be submucous, intramural, or subserosal. So, majority are asymptomatic. So, we get menstrual problems like menorrhagia, intermenstrual bleeding, or painful menstruation because of congestive dysmenorrhea and spasmodic dysmenorrhea, pelvic pain, discomfort, pressure symptoms, urinary symptoms like frequency of urine, retention of urine, and hydroureteronephrosis, rectal symptoms, constipation, feeling of incomplete evacuation, and infertility. So, menorrhagia is because there is increase in endometrial surface area, increase in the vascularity of the uterus, pelvic congestion, interference with normal uterine contractility, stasis and dilatation of the venous plexus, associated endometrial hyperplasia, hyperestrogenic state, and polymenorrhea due to coexisting cystic ovaries and pelvic inflammatory disease. We get intermenstrual bleeding due to ulceration in the submucous fibroid or because of polyp. Pain occurs because of congestive dysmenorrhea, increase in the vascularity of uterus, venous stasis, and pelvic congestion. That is congestive dysmenorrhea. Whereas spasmodic dysmenorrhea is because of submucous myoma, where uterus tries to expel the fibroid polyp. Pelvic pain and discomfort, they are mainly because of large myoma, and women will experience discomfort and dragging type of pain. Acute pain is because of torsion of subserous fibroid and then red degeneration within the fibroid with the pregnancy or ossipils use and sarcomatous degeneration. So we get red degeneration, subserosal fibroid torsion, then sarcomatous degeneration. So infertility in the fibroid may be because of submucous myoma, which causes thinning of the endometrium, and there is ulceration of the endometrium, poor vascularization, cavity distortion. Tubal factor, if it is cornal fibroid, which causes tubal block and affect the tubal motility, impaired gamete transport. Tubes may even be overstretched, associated with PID and endometriosis. Cervical fibroid, sperm transport is impaired if it is cervical fibroid, and cervix is displaced from vaginal pool. Associated anovulation, hyperestrogenic state, endometriosis, PID are the causes for infertility in fibroid. Coming to the complications, you can get torsion, infection, hemorrhage, infertility, endometrial CA, inversion of uterus, sarcomatous degeneration. Secondary changes are hyaline, cystic, atrophic, calcareous, sarcomatous, and degeneration during the pregnancy when OCPs are used. So what happens with pregnancy with fibroid? Submucosal fibroid, recurrent pregnancy loss, spontaneous abortion, can go into preterm labor, red degeneration of fibroid, malpresentation, abnormal uterine contraction, abruption, then increased risk of operative delivery, and postpartum hemorrhage, atonic. So red degeneration occurs because of thrombosis of the vessels which are supplying the fibroid and extravasation of the blood pigments seen in fibroid complicating pregnancy or with history of occipil use. So treatment is rest, analgesics, antibiotics, and hydration. Never attempt surgery for red degeneration during the pregnancy. So what are the history? History suggestive of menstrual problems like profuse bleeding, pain during menstruation, frequent periods, intermenstrual bleeding, or mass in the abdomen, profuse bleeding PV, pain abdomen, pelvic pain, discomfort, heaviness in the lower abdomen, then infertility, pressure symptoms because of huge fibroid, edema, varicosities in the lower limbs, and urinary symptoms like frequency, retention of urine, rectal symptoms like constipation, feeling of incomplete evacuation because of posterior wall fibroid and posterior cervical fibroid, vaginal discharge due to fibroid polyp, anemia symptoms like lethargy, palpitation, chest pain, dyspnea. 30 to 50% are asymptomatic and they are found only incidentally. Coming to clinical examination, mass per abdomen, It is midline mass, firm mass, restricted side to side mobility. Whereas ovarian mass, you get nicely side to side mobility. So lower border is not felt except in case of pedunculated subserous fibroid. Speculum, cervix is visualized. Note for its displacement or presence of any fibroid polyp protruding through the cervix or from the cervix. Bimanual examination, uterus enlarged, uniformly enlarged or irregular in multiple fibroid. Mass continuous with the uterus, movement of cervix transmitted to the mass, groove sign absent. Differential diagnosis for fibroid are full bladder, pregnancy, ovarian tumor, adenomyosis, endometriosis, chocolate cyst, hematometra, pyometra, endometrial carcinoma, uterine sarcoma, pelvic kidney or bicornuate uterus. So my investigations, routine investigations and some specific. Routine like hemoglobin, PCV, look for anemia, then ultrasound, look in the abdomen and pelvis. So it is mainly for mapping out of the fibroid, location of size, site, number of fibroids and type, whether it is submucous, intramural, and how is endometrial cavity thickness, ET thickness, cavity distortion, any adnexal mass, associated adenomyosis or pressure effect like hydroureter or hydronephrosis. This is the importance of ultrasound in fibroid. Other investigations are saline infusion sonography for submucous fibroid, hysteroscopy, and submucous fibroid up to 4 cm can be resected through hysteroscopy. Then laparoscopy when fibroid is associated with infertility to rule out tubal factor, associated endometriosis and PCOD. And intravenous pyelogram for large fibroid, broad ligament fibroid and in cervical fibroid. So there may be dilatation, kinking or alteration in the course of the ureter in large cervical and lateral fibroid. CT and MRI when the diagnosis is inconclusive. So fibroid uterus management. Fibroid should be treated with, if it is symptomatic fibroid or if it is asymptomatic, if it is more than 12 weeks size, or fibroid is the sole cause for infertility, rapidly growing fibroid, and fibroid with pressure effects like hydronephrosis. Conservative management, if the size of the uterus is less than 12 weeks and patient asymptomatic, so slow growth rate of fibroid less than 6 weeks per year, and periodic examination follow up the patient is ready every 3 to 6 months to ensure that tumor is not growing rapidly. So medical management, first is to treat the anemia, give iron supplementation, control the menorrhagia and pain abdomen, that is by NSAIDs, tranexamic acids and our mifepristone RU486 25 mg daily for 3 months, or gestinone 2.5 mg thrice weekly, isopresinol, again it is an anti-progesterone, selective progesterone receptor modulator, again 25 mg for 12 weeks. GnRH analog, that is injection 3.6 mg monthly, leuprolide acetate, not more than 6 months because it causes osteoporosis. Aromatase inhibitors like letrozole, danazole now not used because of side effects, androgenic side effects. Coming to the medical treatment principle, so steroid hormones responsive tumor, it is a steroid hormone responsive tumor because we are giving all those progesterone receptor analogs, anti-progesterone, so it is a responsive for steroid hormone. Once molecular biology of fibroid is well understood, angiogenic factors and growth factors may serve as a targets of therapy. So usefulness, you should correct the anemia and can correct the menorrhagia. We can even reduce the size of the fibroid, blood supply of the fibroid preoperatively. So route of surgery changes from laparoscopy or vaginal hysterectomy, decreases the size, reduces the pressure symptoms. Steroid responsive, the treatment are GnRH agonist, antagonist, selective progesterone receptor modulator, mifepristone, then danazole, then estrogen, selective estrogen receptor modulator, that is ormeloxifene actually. So disadvantages, side effects of GnRH analog, it causes menopause like symptom, so not more than 6 months, and cost of the drug is more, and after stopping the treatment our tumor can regrow. Then there is failure of the treatment or recurrence of the symptoms, and surgery is the last stay of treatment. So it is costly. So we get hot flushes and osteoporosis. After stopping for 6 months, there is regrowth of the fibroid. So other some of the conservative surgeries are myomectomy. It can be done through hysteroscopy, laparoscopy or laparotomy. So if you want to preserve the reproductive function, and when fibroid is the sole cause for infertility and you have to remove the fibroid causing recurrent pregnancy loss, and when the young lady wants her menstrual function to be retained. So prerequisites for myomectomy. See, myomectomy prerequisite is it should be done only in the pre-ovulatory phase to reduce the blood loss. Okay. Whereas all the scan investigations are done in the secretory phase, but surgery is done in the pre-ovulatory phase. And rule out other causes for infertility like tubal factors, anovulation, male infertility has to be ruled out. You should have good semen analysis. Adequate blood has to be preserved. Consent for hysterectomy has to be obtained along with myomectomy. If there is profuse hemorrhage during the myomectomy has to be explained, and consent for hysterectomy is must. And preliminary endometrial biopsy has to be done to rule out endometrial carcinoma. So complications, it can be primary, reactionary, secondary hemorrhage. So to reduce the hemorrhage, we will use energy sources like diathermy or harmonic scalpel, injection vasopressin in the tumor bed, and Boni's myomectomy clamp or tourniquet at the level of isthmus. Trauma to adjacent structures like bladder, ureter, rectum, bowel, infection, intestinal obstruction, paralytic ileus, adhesion, rupture of uterus in subsequent pregnancies, and scar endometriosis. So these are the complications of myomectomy. Newer modality are uterine embolization, magnetic resonance guided high intensity focused ultrasound. So depending on the age, parity and symptoms, women more than 40 years who have completed the family, fibroid with the CA, large fibroid with pressure symptoms, and in the symptomatic fibroid, hysterectomy is the permanent cure. So if woman is more than 50 years, we will do even prophylactic oophorectomy. If there is family history of familial cancer or associated tubo-ovarian mass or endometriosis, even before 50 years, we will proceed with oophorectomy. So in conclusion, this is a brief video for fibroid. Fibroid is a benign uterine neoplasm. Fibroid is seen because of hyperestrogenic conditions. Rarely new fibroid appear after the menopause and it tend to shrink after the menopause. Menstrual disturbances, infertility, pain, lump in the abdomen, pressure symptoms are the clinical symptoms associated with fibroid. Secondary changes are hyaline, cystic, calcareous degeneration and sarcomatous changes. Red degeneration occurs during pregnancy, should be conservatively managed. Treatment can be expectant, medical, minimally invasive surgery or surgery. If you want to do myomectomy, consent for hysterectomy has to be taken and woman has to be counseled regarding the recurrence. Hysterectomy after 40 years in a symptomatic fibroid who has completed the family. And now the newer modalities are MRI guided focused ultrasound and uterine artery embolization. This is what about fibroid in brief. Thank you.